Good afternoon. My name is Marianne Hayward, and I want to talk to you today about the South Lanarkshire Treatment Room Service Road to Improvement. This improvement project started in 2018, 2017, 2018, so therefore it's prior to the COVID period. To give you an overview of what we mean by the treatment rooms in South Lanarkshire, they're split across 4 localities: Rutherglen, Camglen, Hamilton, East Kilbride and Clydesdale. And the table there gives an indication of the population they serve and the staff within them. By far the biggest population in terms of providing for the treatment rooms is in Hamilton at 119,000, then East Kilbride at 91, Rutherglen and Clydesdale at 60. And these treatment rooms provide an essential service for GPs across South Lanarkshire, taking pressure in terms of service provision from these GP practices and providing quality service. In this presentation, I will outline the service improvement process, the change management we undertook, the partnership working, service improvement impacts, and some of the financial impacts. So in 2017, when we first started to scope this programme, we had defined the project and identified a leadership team, putting a vision and timeline in place. And step 2 was July 2017 to September 2017 to understand the process, understand the needs of our service users and customers, process map and collect data. We created a treatment room improvement steering group as a guiding coalition and developed an action plan. We reviewed the past. There was a lot of information which had been done prior to this, particularly led by the North, looking at how treatment rooms could be improved. Set up a timeline for a year to do this programme up to 2018. We process maps through various engagement events, service user questionnaires, staff and referrer forums, and we put in process data collection. So our initial findings were quite interesting. There was varying processes and standards of care, all high standards of care, but varying different ways of people doing things. There was varying waiting times, quite high DNA rates and cancellations. Service user feedback was generally very good, and to the point where people were asking us not to ask them because they were very happy with the service and didn't know why they were asking. We asked referrers, so GPs, what they thought of the service, and we did a number of staff feedback sessions on how they were feeling about the service. And we looked at other areas of impact in the system, whether it was acute, on our labs and transport. So the feedback from customers or service users was the following. They wanted no waits. They preferred us to be on time. They expected friendly, smiling staff, suggested names on the doors, suggested dementia friendly. And then one of the biggest compliments was, keep doing what you're doing, it's great. So the feedback was very, very good. And that didn't mean we sat on our laurels. We'll continue to encourage patients to put in patient opinion wherever possible. Customer feedback was very interesting. People were waiting too long for appointments was their perception, and they wanted to know why appointments were 10-minute slots, and because in their minds this should have been much shorter. Of course, we're now in a COVID era where 10 minutes is aspirational because a lot of the appointments are now 15 minutes, but we'll come back to that later. So why was there differences as well across localities in terms of access? So some areas had quite high waiting areas, waiting times, and others didn't. And why was this happening? And people should be going straight to the treatment rooms for suture removal. Why was it going to the GP? And this was really the referral pathway from our acute colleagues coming through outpatients, going to their GP for basic suture removal when they could go straight to their treatment room. From a staff point of view, there was a high absence rate across the treatment rooms at this time. There was feedback on spoilt samples because there was a process where urine samples were being dropped off, particularly in a couple of practices where it was causing a lot of problem in terms of waste and time. People cancelling or do not attend, which could waste appointments. There didn't seem to be any value they felt in treatment room work. They didn't feel it was a profession that was recognised across South Lanarkshire, and any development and training would have been appreciated. The complaints were generally from GPs, they felt, but they also felt some patients weren't happy. So we looked at the data. We looked at what a full capacity, if we were looking at a full day of bloods, how much that would require in terms of staffing. We were rarely full capacity due to lab pickups times, so that was a problem. And that was more of a deficit that leading to the 1 to 2 hour waits. And we also had a 4 to 8% DNA rate. So our routine bloods, our fasting bloods and our urgent bloods were averaging 375 over 5 days. We wanted to create a vision which reflect the findings of stage 1 and 2 and improve access, reduce DNAs and embed the improvements, identify some short, medium and longer term goals and identify leaders for each work stream. Our overarching improvement statement was South Lanarkshire treatment rooms deliver high quality care for our customers and keeping it nice and simple. So this was our improvement areas that we were focusing on. Waiting times, so we're reviewing our demand and capacity, and we had a data manager, treatment room lead looking at this. Do not attend rates, reviewing why people do not attend, conditions, time of appointments, customer feedback. Again, reviewing environments across the treatment rooms in terms of service user experience, satisfaction. And we established a staffing forum to look at training, competency, and really increase the professional identity of people working in the treatment rooms. Further satisfaction was GP forums, acute meetings, and that happened, and developing a standard of care across, a consistency across each of the different treatment rooms in our localities. So access outcome staff numbers were increased in areas where demand did not meet capacity. That was further enhanced later on down the line by the primary care improvement funding, which increased the access to phlebotomy. We had initially 3 band 2s, approximately 27,000, and various tests are changed to help improve the access and reduce the waiting times for appointments. And that included a successful pilot in East Kilbride, where we increased the bloods done a day from 42 a day to 210, which made a remarkable difference to the waits in that particular area. Bloods and Go worked extremely well in Hunter Health Centre, and that was due to, I think, to mainly a captive audience of GPs within the building. So drop-in bloods were achievable. When you look at other areas where treatment rooms are standalone and they're away from GP practices, drop-in bloods or Bloods and Go is quite difficult to achieve, and some of the other areas have tried it and it hasn't been successful. But it works when you have a building with lots of GP practices in it and a treatment room option around Bloods and Go. That's been challenging through COVID due to infection prevention control procedures. However, the team are reviewing it now along with appropriate professionals to see if it can be achieved going forward. And clinic schedules were reviewed in order to improve staffing at times of high demand. The steering group has continued and still continue to work all the way through COVID as well, trying to keep treatment rooms going. An action plan was established with timelines. Communication was good all the way through this. And there were some short-term wins, for example, Bloods and Go, and some of the pathways from acute in terms of suture removal were the ones I'd noted. And then there was a continual review and evaluation all the way through the process. We initiated a We Are Listening To campaign and flash reports for referrers and the staff forums, which is carried on all the way through this period and will do beyond. Our outcomes for waiting times were extremely positive in terms of fasting bloods and urgent bloods, but probably less so. It's a bit flat and compared to the others, which were more routine programs that didn't have in effect waits. And that's something we need to come back and review now that we're moving into a post-COVID era or living with COVID era. We looked at DNAs, and it's no surprise that vitamin B12 DNAs were the highest, and that's because they don't come back to the treatment rooms with frequency or as they do with the other treatment room options. And we worked with people to try and improve this by creating opt-in and reminders for people to come back for their appointment. We reduced DNA significantly by improving the way the clinics were set up, giving more information and reminding people of their appointments. And by July 2017, and unfortunately I don't have enough more up-to-date graph, this continued up until the point where the treatment rooms were stepped back down due to COVID. And that's something we'll be revisiting in the current timeline. Staff sickness also reduced significantly during this time. And again, this is something that we'll be revisiting now that we're coming back out of COVID and restarting services. So the impacts were significant. We had reviewed our demand and capacity and had investment of band 2s and band 3s across the 4 localities. We saved approximately 40 appointments a week in DNAs, say approximately £1,200. Staff sickness costs were difficult to quantify, but retention of staff has been higher and the turnover has been less during that time. And we put our standard of care in place and a measurement plan to support. What we'd like to do longer term, and unfortunately this was stalled due to COVID, was develop a treatment room dashboard against this standard so that it's open and transparent to all our referrers and that staff can see the improvements that they're making. Continue to work with the primary care improvement plan. We've had significant investment in the present tense around staffing and buildings and supporting to expand our treatment rooms. We've been interlinking with the vaccination programme through redeployment of our staff and VTP staff, and we're doing acute bloods within clinics. We're trying to focus on early intervention, prevention, highlighting where we see issues with patients, developing IT scheduling within the treatment rooms, and there's been continued work with labs and transport to make sure we get transport right. We embedded centrifuges in all the localities in the treatment rooms in the south so that we could have pickups at different times and therefore be less dependent on transport. And that is the end of this presentation. I'm happy to take any questions by email as this session has been recorded. Thank you very much.